Perfect. Okay. The first speaker this morning is Eleanor Dunstan, who's going to speak about managing risk in degenerative cervical myelopathy, a service review in response to COVID-19 delays.
Thank you. Okay, so I think we can all recognise that during the pandemic we saw unprecedented reduction in access to treatment for many of our patients. And certainly degenerative cervical myelopathy was a trend that we noted within our team of advanced practitioners that we felt needed a little bit more sort of investigation and highlighting to the not only speciality, the spinal surgical speciality, but to our trust. So this is what this project's about. It's about highlighting the risk of progressive neurological deterioration in a sort of a well-known group. So I'm based at the Queen's Medical Centre. It's a very large hospital. We have unprecedented pressures on our A&E department. There you can see 195,000 attendances to ED alone. It's a sort of a big trauma centre. So there's lots of pressures and lots of competing priorities when you're thinking about access to theatres and surgery. Now, in 2019, we set up a same-day emergency care service specifically for spines, set up with some transformation money to help offload the emergency department and to channel those with non-traumatic spinal disorders to a specialised unit that could manage them within a 24-hour sort of time frame. Now, this is our advanced practitioner team, not surgeons, but deadly with an axe. And they, as physios, really felt quite passionate about advocating for this DCM group because they knew only too well that delay to diagnosis, delay to definitive management can cause really life-impactful changes. So they raised to me during the pandemic that patients started to present with deteriorating neurology. And these were not patients that were new to us. These were patients that actually were on our surgical waiting list. They couldn't access timely outpatient follow-up because we weren't running outpatient appointments. They were just virtual. And they couldn't access the surgery because we didn't have theatre availability. So once we knew this started to become an issue and we started to see an increased presentation, in October of 21, so towards the end of the pandemic, we started to really do a bit more of a deep dive into what might be happening. So we looked at our surgical waiting list and established that there were 45 patients waiting for surgery or for decompression of the cervical spine. We then decided to telephone triage the 45 and took the opportunity to do a baseline MGOA score. Most patients didn't have a baseline score, and also safety net the patients. What we found from telephone triage is that the majority of this group, which is elderly, were either frightened of presenting to hospital because of the risk of COVID, or didn't want to bother anybody, didn't feel that their symptoms were important enough, and actually felt that they were just getting older. So when we looked at that, we actually found from the 45, 18 had reported some level of deterioration. So we performed a clinical assessment on all of those, and we put incident reports in to recognise the delay to treatment had caused some harm. We then discussed the group with our surgical team and prioritised them. 9 were actually deteriorated enough to be listed as emergency, 6 urgent, and then 3 actually remained on a routine waiting list. But from this sort of pool of data gather, we recognised 40% had deteriorated whilst waiting for surgery. So really we had to reflect on that as a division and a trust because we caused harm to those patients. So it became known as collectively the myelopathy risk. This was initially raised at speciality level, which was spinal speciality. It then went to the divisional level, which was surgery, and then appeared on actually the trust level. And that was really important, establishing risk through all tiers of the trust to make sure when we were looking at priority for theatre access, this group was well represented. Because of the data we gathered, we categorised them into high severity and high risk. They were presenting frequently and the chance of harm without improvement post-surgery was high. They needed a regular review and immediate action. So we set up a task group, we safety netted everybody, we continued to monitor them, and we, most importantly, re-evaluated our pathway for this patient. So again, out of things like COVID, it was an unprecedented sort of nightmare for many people, but good things do come. We evaluated it. We looked at seeing all our DCM patients within a 2-week time frame so we can get early monitoring, baseline scoring using MGOA. We safety netted them, and we are in current development with the East Midlands Spinal Network to develop a safety card to give out to patients. We have a surgical MDT for all these patients, and we also now have a pooled surgical list so that we can get them to theatre when theatre is available. So this is just the advanced practitioner team paddling in the same direction to make progress. And I think this really epitomises getting everybody on board to make progress and move forward needs involvement, and that's what we did with this project.
Any questions?
Thanks, Eleanor, for an excellent presentation. Just how long were the patients on the surgical waiting list?
Well, so we don't exactly know, but within the 12-month period, that's how far we went back. So they had been waiting no longer than 12 months, but some were 6 months, some were 3 months, so a variety.
Anything else?
Thank you.
Thanks, Ellie.
Thank you.
Matthew Dixon. Matthew's going to talk about now or later, emergency versus elective surgery for degenerative cervical myelopathy, a service evaluation from practice.
Morning, everyone. So, obviously, on the back of what Ellie's just talked about, the kind of spinal practitioner team, we see a lot of these DCM patients, and a big question for us really is, when do we operate on them? You know, we all know that surgery is indicated for DCM. We know that timing surgery is important because we can deteriorate if we're not getting to them quickly enough. And in reality, we'd want to get them done as quickly as possible because we know that there's a more chance of a improvement if we get to them sooner. Hospitalizations for DCM are increasing in the UK, but there's still really no clinical guidelines. For me as a clinician, when I see this on a same-day emergency unit, and you have someone who has severe myelopathy, the question is, when do we put scalpel to skin? And can this wait, or does this need to be done right now? And really, this is a question that we need to try and answer in our service. So at minute, as we've just discussed, people with progressive symptoms, moderate to severe MJOA, they need surgery if they're happy to go ahead. We discuss them in an on-call MDT. The rest of you might well have this grading system, but for emergency or urgent cases, either they're listed as a P1, priority 1, emergency, or as a P2, priority 2, urgent, elective. So on the back of that work we'd already just done in 2021 and through, from July to March, we had 75 DCM patients listed. You can see the numbers there. 25 were emergency, with 7 already getting worse from being listed for urgent elective, and whilst they're waiting to get into elective pre-ops and anaesthetic assessments, etc., getting worse and then being crossover to emergency and having to be admitted for surgery. You can see the time there. It's, we really struggle from a perspective of, theatre and with beds, what the bed situation is like in the NHS. So people who are having supposedly urgent elective surgery, you've got people who are waiting for some months potentially. So for us as clinicians, we need to try and differentiate what factors, would mean that we have to admit someone for emergency surgery as opposed to waiting for elective. What we did, retrospective data extraction from their records. So we looked at demographic factors, age, sex, how long they'd had their symptoms, whether they were deteriorating or whether their symptoms were more stable and in what timescale. Obviously the important MJOA score, as we're still using that to categorize things. We looked at many radiological variables, so where the cord was compressed, what level, how many levels, whether there was signal change, what kind of pathology, cord canal mismatches, many things. And kind of your standard bedside examination. So from all this, we extracted those factors and we effectively ran them through the ringer. Our statistician colleague has done this binary logistic regression model to try and figure out what kind of came out in the wash, really. What things differentiated these two groups of patients. And these were our results. So people who were worsening and their symptoms were not as stable, people who deteriorated in the last month, that was the most statistically significant factor which led us to admitting this person, which kind of makes, it makes sense, doesn't it, intuitively. MJOA score, you can see the means there. People who were worse, they had further, they didn't have enough, not as much room to fall further. So, those are the kind of people we want to pick up and stop them getting worse, at least. And interestingly, age. So it appeared that people under 60 were more likely to be admitted for emergency surgery. And these were the only factors. No other radiological variables, no other clinical examination findings. These were the things that kind of came out in the wash. So, from a perspective of what we do now, obviously this is all taken from, our own opinions, and as clinicians we're making these decisions on a daily basis. And there does seem to be a clear a priori difference between these two cohorts of people who we think can wait for later as opposed to being done now. But that's all very subjective, so we're going to do an ongoing data collection and analysis to try and figure out if we can establish a clinical decision tool so that we can make things more standardized, when we want to help these patients. And, in reality, we want to get them all operated as quickly as possible if we're going down that route, but as we all know, the NHS doesn't work like that. So we need to develop this, and that'll be the next plan of action. Thank you very much. Any questions?
Any questions?
Just a question there. You said you're going to develop this decision-making tool. Have you considered using AI or anything like that to help?
AI?
Yeah.
No, I've not considered it. I think the question would be skill and how using AI would, be able to do that. I will refer the stats to my statistician colleagues more so than myself as a clinician, but I think we just need big data, as everyone has talked about. We need to know more. So a bigger cohort, and then potentially using AI or other forms of.
Yeah, the reason I mentioned it, I know in hip and knee surgery,
Sure.
they are using AI now to make those predictions of who will be the people who are going to do best.
Interesting. Yeah. Anything else?
Thanks very much.
Cheers.
Next is Julia Tabara. Can a training workshop on degenerative cervical myelopathy?
Sorry, Jim, can I interrupt you?
Yes.
I'm actually doing them the other way around.
Oh,
So I'm going to do the expert consensus. So you've got to hear me twice, I'm afraid. Sorry.
shall we go with, can an informal expert consensus process be used to identify early, middle and late stage symptoms in degenerative cervical myelopathy? Thanks very much.
And I've got 10 minutes.
Perfect.
I'm going to I just don't
Put
want you
them
to
together.
take my minutes away.
Don't worry, I won't.
So I'm going to do both of my talks together and then questions at the end, if that's okay.
Perfect.
Right, so, and this is my, yeah. So we got together a group of neurosurgeons and physios to look at trying to map the early, middle and late stage symptoms of degenerative cervical myelopathy. This has never been done before, so we thought we'd just use quite an informal, small-scale process to just get the ball rolling. And the rationale for this was really that we know that there's a lack of knowledge on symptom chronology with DCM already, and that's part of the reason why we've got this big problem with diagnostic delay. If you ask Alexa or Google it, a lot of the cord symptoms that you read about are really very end stage. Ataxia, spasticity, paralysis. By the time you've got that, you're absolutely screwed. So what we wanted to learn more about is the early and middle stage symptoms so that we can catch them sooner and get them to the surgeons quicker when there's more prognostic hope. So there's a group of 12 of us, neurosurgeons and physios, and very importantly, we were spread across primary, community, secondary and tertiary care. If you take a group of tertiary care surgeons alone and ask them what the symptoms of myelopathy are, because they don't see people until later on, because we're not sending them soon enough, they'll have a slightly skewed view. So it was really important that we included primary care and community care clinicians to get the full breadth of information. And the process that we used was a survey to capture initial thoughts, an online consensus meeting to discuss areas of disagreement, and then a follow-up survey. And the survey, we wanted to be really careful that we weren't biased in the questions that we were asking. So we used an incidence study by Monroe et al., which is still pending publication. And there's 55 DCM symptoms. Did you even know there were that many? And we lifted them all straight across into the survey to avoid any level of bias. So it was very simple. Here are 55 symptoms. In your expert opinion, based on your experience, are those symptoms most likely to occur in the early, middle, or late stage of the lifespan of the condition? And there were two further columns, don't know, because actually I'm going to be honest, I don't ask 55 questions of my patients. So some of those symptoms were a bit weird and wonderful. People might not necessarily routinely ask them. And also there was a column for no trend, because of course sometimes symptoms happen there, or there. So we were only trying to find the ones that consistently happened in the early, middle, or late stages. I think I've said all of that. And these were the results. So interestingly, these red guys over here, in case you can't read it, these are the ones who are going off their legs, paralysis, spasticity, bladder, and bowel. So there's no massive surprises there that those are all late-stage symptoms. But what this is useful for is making us think, right, let's stop waiting for them to tick all of those red boxes before we send them through to secondary or tertiary care. Those are late-stage symptoms. In itself, that was useful to confirm. But what was even more useful is picking up on some of these early and middle-stage symptoms. So early stage, bilateral hand numbness, symptom variability, and neck pain. Unsurprisingly, middle stage, arm numbness, clumsiness, dexterity, heavy legs. Interestingly, muscle spasms in the arms came out as a middle stage symptom. So it might be that spasticity happens in the upper limbs before it happens in the lower limbs. So in summary then, this was an informal expert consensus process. It was not watertight or large scale, but it was better than nothing, which is what we previously had. And we have started to identify some early, middle, late stage symptoms, which could hopefully help to facilitate earlier recognition. But we definitely want to do a follow-up study, which is larger scale, more rigorous, and with a lived experience voice. So I was chatting to Michael Fellings and Jeff Wilson in Canada last week about the possibility of setting up a larger scale study. And it may be that we invite people with lived experience into that with a survey for clinicians and maybe a slightly adapted survey for people with lived experience, so we can get all of that information under one roof. But the other thing is that Sue Greenhalgh and Chris Mercer are also looking into the feasibility of a qualitative interview study, a more in-depth, small-scale qualitative study to dig right underneath the true depth of symptoms. So please grab me in the break if you're interested in getting involved in that phase 2 study, because we're really keen to hear from anybody who calls himself a DCM geek. I don't know why that happened, sorry. Have you just cut me off?
No. Speak to those guys.
Okay.
That's it.
Was that it? Okay, fine, that'll be why then. I'm going to move straight on and then take questions at the end. So what we did with that infographic that I showed you with the yellow, green and red arrows is we incorporated that into an education project. So what we wanted to do is to measure whether or not a lunchtime training session for GPs could increase their awareness and triage confidence of DCM. And again, the rationale for this was all back to that big problem that we've got with diagnostic delay. And what we did is we designed, so there were, hang on a minute, 6 of us in this group, again, a combination of physios and neurosurgeons. We designed a PowerPoint training package with interactive case studies to practice triage. And I delivered this virtually to my local GPs in Hounslow, Richmond and Kingston, which is West London. We kept it, actually I should say, if you're interested, the slides are on the myelopathy.org website. You don't need to type all of that in. If you just search myelopathy.org/DCM, and when you look at the slides, you'll see that they're very need to know, because GPs are crazy busy. They've got a million people trying to grab their interest. So we kept it very simple. What is DCM? Why do you need to know about it? How are you going to spot it? Like, what are the symptoms? Where do you send them if they've got it? And how quickly do you need to send them? With the interactive case studies, I described a situation of cases that I've seen myself. And at the end of each case, I said, so what are you going to do with this patient? You're going to send them to ED, an MSK triage service, physio, or are you just going to keep hold of them and safety net them? We used a self-assessment survey before and after the training to measure awareness and triage confidence, and we advertised the sessions on email, TeamNet, and LinkedIn. So the good news is that, there's bad news as well, but I'll come to that in a second. The good news is, if you look in this column, the pink column, awareness, Before the training, awareness was limited or average, and after the training, it was very good or excellent. So that's exciting, although, to be honest, most people will increase their awareness when they do some training. But what was even more exciting is that triage confidence also increased. So pre-training, in this blue bit here, there was slight... Has this got a pointer on it? Am I clever enough to... Ooh! Sorry, I get very excited about things. So before the training, their triage confidence was slightly confident or moderately confident. Most people were in those two boxes. By the end of this training, a bunch of GPs, some of whom had never even heard of DCM before, were all either very confident or extremely confident to triage DCM, which was really exciting. Now I've got to work two things. Oh, no, sorry. And the bad news, unfortunately, 23 of them turned up. And that's because, and a lot of my GPs emailed me to say, I really want to come, I'd love to, I'm so interested in this, and I want to support you, but I'm just too busy. So one of the big reflections is that actually GPs don't get lunch breaks, and maybe we should have done evening sessions. But never mind, we all live and learn. Just as another really quick point, because I also did this with a bunch of physios with slightly adapted slides, and on that link that I told you about, there's GP slides and there's physio slides, which are a bit more in depth. Same thing, really. So awareness increased from limited, average, very good to very good or excellent. And then triage confidence was slightly or moderately, and then ended up in the mainly very confident box. So yes, an interactive training workshop can be used to increase GP awareness and triage confidence. A larger scale follow-up study is needed to understand whether or not that translates into reducing diagnostic delay, which we didn't attempt to do. Don't deliver training to GPs in their lunch breaks because they don't get lunch breaks. And what we're now looking at is a more broad, sweeping educational strategy to try and catch as many GPs as we possibly can, because there's not a one-size-fits-all approach. So we're looking at, already the PowerPoint slides are available, but we're going to make them narrated. We're going to come up with a couple of infographics, maybe a podcast, maybe an online module that could be easy to do when you've got an hour spare. We are happy to do some webinar presentations at big ticket events, but what we want is to build a library of resources that people can use themselves without us always having to be there. And the hope is that we're going to build a clinical resources page on our myelopathy.org website where we can host all of these resources, and we'll let you know when that happens. Watch this space. Thank you for listening.
Thank you very much. I'm sure that's going to generate some questions. Anybody want to ask Julia something?
Stunned silence.
Not sure.
Do you have a timeline on when do you think these things are going to be ready?
The educational project's quite massive, as you can imagine, so I reckon it will be at least 2 years before it's fully up and running. But as we develop these resources, we'll be sharing them on social media and putting them on the website, so I imagine it'll be a gradual process. And anybody who's interested in helping, please come and grab me, because we want to make it as brilliant as possible, and the more heads, the better.
And do you see a place for sort of surgical colleagues in this they have those networks, they have those connections as well locally to push out?
To share the resources,
to share the resources, to have a central resource that they can just use.
Absolutely. So we'd love, we had the conversation yesterday about having a clinical resources page on the National Spine Network, which is a multidisciplinary group. These resources could go on the BAS and SBNS networks. We're going to spread it as far and wide as we possibly can, because diagnostic delay isn't just a problem in the UK, it's a problem globally. And awareness is the key, isn't it?
It's a question.
Thanks, Julia. Thanks for that fantastic presentation. Quick question in terms of the impact on your triage service. Has the training changed the referrals, the quality of referrals you get and the information you're receiving?
Such a good question. And yes, immediately the impact was very obvious. Interestingly, we're getting less inappropriate referrals, which is good, because actually some people have got rapidly progressive myelopathy and need to go to ED, like Matt said. So we're getting less of those inappropriate referrals, which is great. but we're also getting more of the right referrals and more of the right information. The thing I kept banging on about to the GPs is that there's a big emphasis on timescales. It's not enough to say, well, they've got dexterity and clumsiness and arms and legs. We need to know how long and whether or not those symptoms are progressing. So now they're giving us that information. We can now decide we need to see that person urgently. Actually, they can wait because it's been going on for a few years and it's not progressive, or actually that one needs to go to ED. So yes, in answer to your question, that's been a really nice side effect.
Thanks. I've got a question relating to whether you've got plans to validate your infographic. Like, for example, you talked about the early, middle and late stage. So the late stage, you know, might there be an opportunity there to look at that relative to MRI changes? Like, would the later stages be patients that would have signal change, for example?
Yeah, I mean, it's so interesting, isn't it? Because some people, you see people with severe signal change and they've got no symptoms at all, and you only scan them because they've got a gammy arm, you know, they've got radicular pain in one arm and they've not got any cord symptoms, and then you can also have vice versa. It's a really good point, and that may well be another good follow-up study. It's not something we're thinking about at the moment, but come and grab me, let's chat. Really good suggestion.
Brilliant. Thanks, Julia. Fantastic talk. Next is Holly Clark, Knowledge and Education of Cervical Myelopathy within Healthcare Professionals.
Thank you for listening to my abstract presentation today on a systematic review I did on knowledge and education of cervical myelopathy within healthcare professionals, which does cross over a little bit with what has already been discussed today. So, as we've already discussed, degenerative cervical myelopathy, otherwise known as DCM, is an underdiagnosed condition that can lead to major disability and reduced quality of life. It's thought to be prevalent in around 2% of the population, with diagnosis taking around 2 to 3 years and up to 5 years in over a third of people. There's a lack of knowledge of DCM pathophysiology, clinical presentation, and management pathways, and this can lead to delays in both diagnosis and management, with studies showing significant delays in referrals to an appropriate specialist. So the aim of this review was to look at the knowledge and education of DCM in a broad aspect of all healthcare professional population, and kind of help us understand really the reasons behind these delays in diagnosis and management. So we conducted a systematic search using databases RMed, Sinella and Medline, and used a combination of search terms around knowledge, education and DCM to identify primary research articles of any design that excluded any narrative case studies, only articles that were of degenerative chain of myelopathy were included, and any articles were excluded where congenital changes, trauma or lesions were the cause of the myelopathy. Screening was undertaken by 3 different reviewers through title and abstract and full text, and then data was extracted into relevant tables to summarise evidence of knowledge of health professionals on diagnosis and management of DCM, alongside education provided on DCM and educational resources available. So the results here in the PRISMA model shows that 316 articles were found, and 3 further articles were found from reference searches also. These were screened at title and abstract, and then further screened at full text, and then there were 33 articles in total that were carried over to data extraction. So the main points that we found from the data was that DCM education in UK medical schools showed that 70% of students reported not receiving any DCM training, and 25% of those who had only received an hour. About 96% of the medical students expressed interest in further DCM teaching. Looking through the medical curricula, DCM was jointly least cited compared to other common neurological conditions. And student performance, however, though was higher than average in DCM question banks, but decreased in questions surrounding DCM management in foundation years. Reported self-rating of DCM knowledge was rated average or better in 21% of students, but this again didn't correlate with the answers to the questions on the DCM question banks. So a single retrospective study had shown that primary care assessments only included light touch and muscle strength testing. History taking directed at signs and symptoms of DCM were not documented other than on the final appointment when they were diagnosed. A further retrospective cohort study also showed that 76% of all new DCM presentations were referred to a speciality other than a spinal surgeon on their primary referral. A lot of these patients were actually referred on to more orthopaedic consultants. Diagnosis of DCM was made in 38.1% of cases by a neurosurgeon and 19% of cases by an orthopaedic practitioner, and in 4.8% of cases by a general practitioner. So in conclusion, there was very limited evidence available on the current level of education around the knowledge of DCM. The evidence that was found only really focused on medics and didn't include other medical professions, and as we know, a lot of the initial presentations are kind of conditions that would be seen by other professionals, particularly physiotherapists. Articles found a consistency in absence or low levels of reference to DCM in education at UK medical schools, and there was an absence of DCM-specific assessments. So the clinical impact from this is that we know that there are low levels of education around DCM during training, and this has been identified from the review, and this may delay diagnosis and management of the condition. So ensuring that it becomes a standard part of health professional training may improve identification and management of DCM, but again, this needs further investigation. Thank you for listening.
Thanks very much. Any questions?
What an interesting review. Can you help me understand how you got from the literature to the frequencies you reported? You know, I haven't got a sense of whether this is reliable and trustworthy literature or not.
In total, the amount of literature that we found that was actually useful was probably about 6 articles, 2 of which were quite big studies done at, across a large scale of UK medical schools. But it was all very limited to medical professionals, so medics, and again, didn't account for any other professions within that. Again, trying to extract knowledge of DCM was very, very limited. So although we found this information, it was down to maybe a couple of studies. So that's why we do need to look into this more, but it just highlights the fact that what was being already discussed in the previous presentations, that there is this lack of knowledge, there is these delays in diagnosis, and why is that happening? So it kind of just gives us an idea of actually we do need to look at this more.
Thanks very much.
Hi. We know that appropriate pathways will probably pick up with the ESPs in the community. With that will probably come as the pathways evolve. With respect just to the GPs, is it on their syllabus for the Royal College of GPs? Do they actually have to learn it as their professional, as part of their training, in the same way that we would have to learn?
I mean, my honest answer to that is I don't know.
I didn't want to bring Julia in on this, but is there anything in there? I mean, is there a...
Currently, and not consistently, although I've done some training to my GP trainings locally, there's patches of good practice around, but we definitely need to do that. And we also need to get into undergrad, medical, physio, osteo, chiro programs, so we can train. I don't know why, but for some unknown reason, myelopathy does not even feature at all in physio undergrad programs, and it's briefly mentioned in a medical program if you're lucky. So you're right, we need to get to people earlier, I think, before they're experienced clinicians who've missed quite a few of them. We need to catch them while they're students, ideally, and trainees.
Sure. So perhaps one for the UKSSB exec to take forward. Thanks.
Thank you. Next is Adnan Sheikh, a retrospective review of clinical and radiological outcomes in standalone cages versus cage screw device for multi-level anterior cervical discectomy and fusion.
Hi, thanks for accepting my abstract. I'm a spine fellow working at Royal Orthopaedic Hospital, and we'll go through the comparison of these two cage systems. Nothing to disclose. So ACDF is the gold standard for degen cervical spine diseases because of the lower infection risk, less blood loss, less post-operative pain, and early recovery. ACDF aids in decompression of nerves and cords. Various cage and plate systems are available. At ROH, we use standalone plates and cage screw constructs. So these are the two commonly used space we use. Well, the left is a standalone, and the right one is a screw. We are going to compare these two. The aim was to compare the clinical radiological outcome of cage screw device and standalone cage for fusion in multi-level ACDFs. So it's a retrospective studies. We got 85 patients. These are 2 and 3 level ACDFs within last 5 years operated at ROH. Clinical outcomes were assessed by pre-op and post-op questionnaire clinical letters. Radiological outcomes were assessed by pre and post-op X-rays and MRI. And standard Smith-Robinson approach was used for all the patients. Clinical outcome measures were a neck disability index, VAS, and neck, VAS for neck and arm pain, and ODOMS criteria, which goes from excellent to poor. Radiological measures were fusion, subsidence, Cobb's angle, and C2 to CS7 SVA, as seen on the X-rays. Now, the results are mainly the number of patients we got in. CS stands for the screws one, so 39 in screws, which were 80 levels, 2 level and 3 level including. And standalone was 46 patients with 95 levels, especially 2 levels and 3 levels. Male-female ratio 27:12 in screws and 28:18 in standalone. Hospital stay was almost equal, 3 days roughly for both groups. Complication rate was also roughly same, 5%, 2 and 3 in both. Follow-up durations, we have 14 months on an average for screws and 12 months. These are mainly at the point where they were discharged. I think it's a retrospective study, but if someone is doing prospective, I think this can be extended up to 2 years. Pre-op radiculopathy was seen in 79% in screws and 78% in standalone. Post-op improvement in radiculopathy was 71% and 84% in these groups. Myelopathy was roughly 45% in both, and improvement was seen up to 66% in screw group and 70% in cage. Favorable outcomes were roughly same in both groups, 70%. Now, this is a NDI chart. Left side is a pre-op and left is a post-op. We see almost 50% reduction in disability index, more with screws. Pain score, we see pre-op on the left side is a VAS score for a neck, and the right is for arm pain. Both, we have more than 50% reduction, and it's roughly 1 to 2 in the scale of 10 after surgery. Now, when we look at the fusion and subsidence, where it gets a bit interesting, we see that the fusion is more in the screw group. But it's not statistically significant, but we see a good percentage, 74% with fusion at 1 year. If we go beyond 1 year, like for 2 years and 3 years, we may see increase in this number, but because of the limitation of study, we have got this. And when we look at the subsidence, it was more in the screw group, which was 52, and 31 in standalone. And when we did the statistics, we found it's statistically significant. So because of subsidence as well, here is a chart, but because of the subsidence, when we look at the Cobb's angle, the Cobb's angle was lesser in screws because of the subsidence. But because a standalone doesn't cause much subsidence, the Cobb's angle was better. We compared with normal, and when we compared in the group itself, we saw when we compared the X-ray, the lordosis gained was less in screw device, was more in the standalone cage. And also we did a MRI versus X-ray. It's not ideal, but in many patients we didn't have pre-op X-rays, so we compared with MRI. So on comparison, group to group, we saw almost similar results. So in conclusion, a comparable clinical and radiological outcome was seen overall. Comparable complication profile, subsidence was found to be significantly lesser in standalone cage as compared to cage screw construct. The odds of achieving fusion were found to be higher with cage screw construct. However, this did not amount to clinical significance. A similar outcome across the two groups is reassuring, and performing a surgery that is quicker and lesser operative morbidity and lesser cost might be the way forward. And a prospective randomized trial will help to prove or disprove this hypothesis. Limitation, as I said, it was a retrospective data. I would go for at least 2 years. Early discharge, so we don't have a long-term follow-up, and cost effectiveness wasn't done in this, which can be done separately via planning. Recommendation, multi-center randomized control trial can be done to compare the two groups. A long-term follow-up with prospective data is needed. Thank you.
Thanks. Any questions? I'd like to ask a question, if I may. What made you go back and look at this in this way? What made you think there would be a difference between these two groups?
Usually there is a debate whether to put the screw or standalone. Standalone cages are 25% cheaper compared to screw. So there was an economic way to compare. We should have done, but because of our restricted time, we couldn't. But in future, we may do. And also, I was interested to look at the subsidence and the COBS. In few MRI, we saw that happening. So we thought we will go back and see what was the difference. Overall, there is not much clinically significant difference. But in future, if we are planning to do, or the aim is to maintain more of a lordosis, a standalone may be preferred rather than, especially in multi-level, because there is less subsidence. Yeah.
Thanks very much.
Sorry, can I ask a question? Thank you. The material of the cages, were they similar? Because the pictures you showed, the standalone was PEEK, and the cage, the one with the screw was titanium.
Yeah, it wasn't similar. So mostly the PEEK in the standalone, and we also have some hybrid of PEEK and titanium. But the screw one was mostly titanium with the screws.
Yeah, but that's immediately the reason why you have the difference between the subsidence, because of the PEEK's ability to be less invasive.
Can I clarify that one? The cage screw contract is mainly PEEK also. Few of them are titanium, but mainly a PEEK. Both of them are mainly PEEK construct implant. So there was a mixture? Yeah, for the cage screw construct, a few of them are titanium one, but mainly the PEEK with titanium coating, similar to the CA Space one, the cage element one. Okay, thank you.
Yeah.
Thank you.
Okay, thank you.
Next, Sophie Gatfield, collapsing corpectomy cages, a cause for concern.
Thank you very much. My name is Sophie Gatfield. I'm a trauma and orthopaedic registrar in the Southwest, based in Taunton. Thank you very much to my colleagues who helped with this project, and we have no conflicts of interest. So as we've heard, degenerative spondylitic disease is very common, and cervical corpectomy is commonly performed for cervical stenosis. And that may be due to trauma, infection, neoplasia, or OPLL. Expandable cages are used to support the anterior column of the cervical spine following corpectomy, and the expansile nature of a cage allows adjustment to anatomy of the patient or to the procedure performed. Generally, literature is supportive of their use, and hardware failure that's reported in the literature is uncommon. So this project was designed after routine follow-up of a 58-year-old patient who'd had a C5 corpectomy and implantation of a globus fortify, showed complete collapse of the expandable portion of the cage on the radiographs. So this can be shown here. The expandable portion in the intra-op films is the thread height there, and in the post-op 3-month review, that portion had collapsed. So this specific patient had quite significant pain, and an MRI scan showed buckling of the ligamentum, associated myelomalacia, and he ended up having revision surgery. We'd been using the globus fortify at this point for about 7 years in Taunton, and so we hypothesised that there may be more cases, given he just presented to a routine follow-up. So we looked back at all the cervical spine procedures that had been performed in our unit since 2015. We used the British Spine Registry, and we also used our local theatre system to make sure we got all the cases. And we include all cases where cervical corpectomy was performed, specifically with Globus Fortify being implanted by the anterior approach. We looked at AP and lateral intraoperative views, and we looked at, as shown, the thread height of the expandable portion of the cage, and then we compared that to post-operative imaging. The difference in the thread count was calculated, and then all of those x-rays were looked at independently by 3 raters. So we had 1,500 patients undergoing cervical spine procedures, and if we narrowed that down by our inclusion criteria, we ended up with 71 cases to look at the x-rays. On average, 61 years at the time of operation, and 52% male, 48% female. And of those 71, we identified 3 cases of complete collapse. That's including the one you've already seen, so that's 4%. Another case here, intraoperative film showing the thread height. Day 1 post-op, immediately maintaining the thread height, but at 6 months, complete collapse of that expandable portion. You can see the change in angle of the screws as a result of this. The case on the left you've already seen, and then a final case where the cage had collapsed. In addition to those 3 cases, we found 5 cases where there was possible partial cage failure. And what we mean by that is there was a change in the thread height. So 5 threads visible, 5 threads visible day 1, and then just 4 at the 3-month follow-up. That was replicated by informal measurements on the X-ray radiographs as well. So 4 more cases similarly where there's not complete collapse, but the thread height's definitely changed, and that was in agreement from all 3 independent raters. On average, the changes were noticed at 3.75 months post-op, and the cases involved 4 of the 5 surgeons in our unit. There should be some limitations acknowledged. So one of the cage failures didn't have an anterior plate, so it's a slightly different procedure. The x-rays are sometimes difficult to see. We've all looked at lateral x-rays, which are slightly more oblique than they ideally would be. So it can be difficult to interpret, especially those borderline cases. And the procedure was slightly different in different cases. So some were single level, some were multiple level. And then one of the cases of complete collapse, the patient did have some trauma, so it's unknown whether or not that was contributory. So moving forwards, now I've said we're currently not using the cage system while making ongoing assessment, and we were interested to know where this is happening elsewhere. We did, of course, identify MHRA, and all the 71 patients that were involved were invited in for clinical review. The following on from this, speaking to Globus have done their own investigation into this, and we have identified that this is a site-specific issue. This isn't something that's been happening elsewhere, which is very pleasing to know. The affected cage, one of the cages from the complete collapse, was sent off for investigation, so they've taken it appropriately seriously. So these are our references, and I thank you very much for your time.
Thank you. Any questions?
Hi, nice. Is there any common factor among the surgeons or done by the trainees of those 4 cages which is complete collapse?
Unfortunately not. We really wanted to find a reason, or whether it was just someone doing something wrong that was easy to sort out. And it's obviously fortunate that there was only one case where the symptoms recurred and the patient had to go back to theatre. But we couldn't find any other reason. It would appear that there was a mechanism that wasn't quite clicking, that has been the suggested cause of this issue. But I think we're most relieved that it's been identified and sorted out. That was the main benefit of this project.
Apologies, I might have missed this, but is this the series, is it just one implant or is it multiple manufacturers?
Just the one implant, the Globus Fortify. So we excluded other implants that were inserted in our unit from the project.
Okay, thank you.
Sorry, I'm nowhere near a microphone. Just a very quick question. Have you removed any of these cages that have failed? And if so, have you sent them anywhere for review?
Yes, just the one, and that has Globus have sent that off. I don't know if there's anyone from Globus here.
Sent through Globus as opposed to being sent to one of the treatment centres?
Yes.
Okay, thank you.
And what plates was on top of all that? And was it a locking plate? And if so, how does the screw integrate into the plate?
So what's tricky about this project is that the different cases were slightly different. So I can't tell you that for all the individual cases, but it will be slightly different in each scenario, which means it is difficult to draw generic conclusions, I appreciate. But I guess the main point was to identify that this was happening and make sure we worked out why it was happening. So I don't know.
That might be worth looking at, because if you've got a plate that's locking and load sharing whilst the cage is incorporated, it may just be that there's too much overload on the implant.
Yeah.
Yeah. And they all absolutely integrate to lock, or they've just got the turn key to go over the top of them?
So they've got the screw and then the small pentaplate screw over that.
Yeah. Okay, thanks.
Thank you.
Thanks, Sophie.
Thank you very much.
Next is Siddharth Vankipuram, clinical and radiological outcomes following standalone anterior cervical discectomy and fusion for 3 or 4 level cervical degenerative disc disease.
Thanks. Hi, my name is Siddharth, and I'm here to present the Queen Square experience for standalone ACDF with the zero profile cages with integrated screws for multi-level disc disease, and quite similar to Adnan's talk, except we defined multi-level disease as 3 or 4 level disc disease. Yes, so single level or 2 level ACDF outcomes are widely reported. We know that outcomes are good. Fusion rates are more than 90%. And with multi-level disease, the challenges or the considerations to be thought about are what levels are involved and what levels need to be actually operated on, whether we go anterior or posterior. And of course, with traditional posterior approaches, whether it's a laminectomy or laminoplasty or laminectomy with fusion. If we're going anteriorly, do we do standalone or standalone with screw, or do we include a plate? And then, of course, when we look at complications when we're going anteriorly, we think about things like dysphagia, non-union, and adjacent segment disease. So the purpose of the study was to essentially identify the outcomes following a standalone ACDF procedure using zero profile cage with integrated screws for multi-level cervical spondylotic myeloradicalopathy. And we included only patients who were symptomatic with 3 or 4 level disease and who had a minimum of 1 year follow-up with us. We excluded all patients who had an additional posterior fusion, the pediatric age group, or if ACDF was done for trauma, tumors. And also, we did not include OPLL in this series because, again, the criteria for management is slightly different. Similar to what Adnan has shown, these are the 2 most commonly used materials that we used. So either use the left one is the NuVasive version, which has 3 screws. The right side is the Depu 0P, which has 4 screws. Very easy to use and quite user-friendly. Looking at the results, we identified a total of 34 patients in our series retrospectively from 2015 to 2022 with a mean age of 58 years. 9 patients of these were smokers actively during the time of surgery. And those are the levels that have been mentioned most commonly. Again, C4-5 and C5-6 are the most commonly levels been operated on. Things that we also looked at were 24 patients had 3-level surgery done, 10 patients had 4-level surgery done. Mean follow-up was actually pretty good at 26 months in the series. And looking at the operative time, which is important because that kind of determines the amount of dysphagia that they could have, it was on an average 180 minutes from start to finish. The length of stay was about 5 days in the entire cohort. Looking at the clinical outcome measures across all parameters, the VAS scores for neck pain and arm pain, the neck ODI, as well as the NJOA scores, there was statistically significant improvement in all of these outcomes. And then in terms of just looking at a few pictures, these are some of the work that we've done in terms of the 3 and 4 level disease. Generally pre-operatively, we don't do x-rays. In only a few patients we've actually done x-rays. When there is a suspicion that there could be potential OPLL, we do a CT scan. And if that patient did have OPLL, wouldn't have been included in the series. Looking at complications, 1 patient in our series actually did have a wound infection and required to go back to theater. Another important advantage of this technique is the hardware-related complications, and only 1 patient actually had a hardware complication of a broken screw. It was asymptomatic and did not actually need anything done. Dysphagia was something that we looked very closely at, and we defined early post-operative dysphagia as those patients who had swallowing difficulties after 48 hours of surgery and then required either intervention with an NG tube or required steroids and required a salt assessment. 6 patients in our series actually did have early transient post-operative dysphagia, which resolved within a couple of weeks. None of our patients, in fact, had late post-operative dysphagia. No patient had C5 palsy, nerve palsy in the series, while 2 patients did have transient dysphonia as well. Interestingly, when we looked at 2 important parameters, which is adjacent segment disease and symptomatic non-union, we found none of these patients to actually have that. And this is just the 2 patients who had the complication, one with the wound infection and one with the broken screw. So in a sense, I think zero profile cages and screws have a very high rate of fusion, no additional plate required, no additional posterior fusion required. Transient dysphagia rates of 18% in the early phase, which all of them improve. And we found that with our experience increasing and our operative time reducing, this actually helped reduce the rates of dysphagia. Looking at radiological parameters, we didn't have preoperative X-rays as mentioned, so it was difficult to kind of do a preoperative and postoperative comparison. But this was the Cobb angle and the cervical SVA postoperatively. And we found that that was within range, and therefore is restoring sagittal alignment improved with better clinical outcomes. And then if I think about multi-level ACDF versus posterior cervicothoracic decompression and fusion, for me it's a no-brainer. You have less amount of pain, less incidence of C5 palsy, less incidence of hardware complications, less wound infection as well. And then just thinking about this, whether multi-level ACDF, can it actually protect against adjacent segment disease? Because a lot of our patients had C5, 6, C6, 7 that were actually infused, and those are the most common segments where you get adjacent segment disease. We also looked at pseudoarthrosis very, very carefully, and so all those patients who had symptoms underwent extensive investigation with both CT SPECT scans or flexion extension X-rays, and in our series it was actually 0%. So to conclude, I think standalone cages are a very valid alternative in multi-level disease, and the high fusion rates, low rates of dysphagia and hardware complications, along with adjacent segment disease, make this technique quite useful. Thank you.
Thank you very much. Any questions from the floor?
Yeah. So I would say that pseudoarthrosis, I should show that it was symptomatic non-union was 0%. So the fusion rate was 100%, I would say. Yeah.
Have you got any recommendations for your surgical colleagues based on your findings?
There's a question there, but I'm...
Oh, I do apologise.
You made a number of conclusions there and recommended full-level ACDS without any comparative to any other treatments. So you didn't reference any scores or improvements, complication rates for standalone cages or cage system with plates or posterior decompressions.
Yeah. No, I mean, I think posterior decompression was the traditional gold standard for patients who had 3 or 4 level disease. But in comparison, I think when you talk about things like C5 palsy, hardware complications, they're typically higher in patients who have posterior surgery, or even ACDF with plate, where the hardware complications are higher. So I would think in this group, I think the standalone cage with screw is probably the better alternative for these group of patients.
Thank you very much.
Oh, well, one last question.